Gary Bennett, and I direct the Duke Global Digital Health Science Center, and we're really, really pleased today to have Lana Moriarty, who is the director of the ONC's Office of Consumer eHealth. And in that role, she provides strategic vision and leadership to the consumer team. And our team just had a really lovely lunch with her and got to learn a lot more about what she does, and I'm excited for her to talk about what she does with all of us. Prior to joining the ONC, Ms. Moriarty worked on behalf of underserved populations here and abroad. She worked for the NHSC and the Nurse Corps, and prior to HRSA, she was with the World Bank, and she's also a Peace Corps volunteer. Those of us familiar in the Global Health Institute, that carries a lot of credibility. And she worked in several West African countries on issues related to HIV education and prevention. She's an MPH from the University of Maryland and a bachelor's degree from Auburn. And that's okay, we'll still let you be here. But I think what was really great for us is that I got a phone call completely out of the blue from one of our mutual colleagues who said, it really says a lot about what Duke is doing to have somebody like Lana join you for this kind of talk. She's perfectly positioned to really make real change. And so that, I think, speaks volumes. So we're really excited to have you here. Welcome.
Well, thank you for that very warm introduction. I hope I live up to your expectations. It's just wonderful to be here. I think one of the great things of this role, leading the consumer team, is that not only do I get to work across ONC with all of our offices, keeping consumer at the forefront, but I get to work across our federal partners and most importantly, across the private sector. So I was telling Dr. Bennett that I just was in Chicago meeting with a group of startup companies there and finding out what they're trying to do for healthcare. So this landscape is rapidly changing, so it's very exciting to be here. So I'm going to start out today and tell you a little bit about where we stand with putting patients at the center of their care and empowering them to be more valued partners, because it's all about improving the partnership between patients and providers and really leading towards better care coordination, shared decision-making. And we'll talk a little bit about the challenges and opportunities that we see, describe our vision for the future, and talk about how ONC and HHS is using policy, regulations, and tools to help patients become more engaged. I think that I was especially encouraged at this year's HEMS. I just returned from Chicago, and to see such a consumer focus there. There's a lot of talk about patient engagement, and I think that tells me and my team that we're going in the right direction. So we are unlocking data today for shared decision-making and care settings, in the claims space for cost transparency and smarter spending, and unlocking data for interoperability. And interoperability for me means providing care when and where the patient needs it. So we're a long ways away, but hopefully we're moving there with conversations like this. And this really gets us closer to better care, smarter spending, and a healthier nation. So I'm going to start out by telling you about the Office of the National Coordinator for Health IT. This office under HHS coordinates the nationwide efforts to implement and use the most advanced health IT. So a lot of our work has focused with meaningful use on adoption of health IT, and now we're moving into patient engagement as well. And also supporting electronic exchange of health information. This has been done through our health information exchanges, through our regional extension centers, and there's other opportunities as well that I'm going to tell you about today. So we view our primary role, as a catalyst and a convener for advancing patient and family engagement through health IT, rather as a leader. So this just kind of shows the different ways that people think of us, but really we feel that gathering thought leaders and convening conversations like this can help inform our policies and our standards and the work that we do at ONC. So this sort of illustrates what we like to call the perfect storm, forces outside of ONC and HHS coming together to push consumer engagement forward. this is happening in the healthcare marketplace today, and it really is driving improvements in consumer e-health. The ACA necessitates greater consumer engagement, and we continue to see many drivers supporting this, including changes in the way we pay for and deliver healthcare. Policies that are aligning to support the data flowing through meaningful use, through CLIA and HIPAA, along with changing consumer expectations and an increasing financial burden on consumers to shop wisely. So all of this, yet little data seems to be flowing to consumers. I'm sure many of you have heard of the recent announcement from Secretary Burwell that HHS has set a goal of tying 30% of traditional fee-for-service Medicare payments to quality or value, so moving from volume to value through alternative payment models. And this is such as our accountable care organizations, bundle payment arrangements, and all of this by the end of 2016. And then tying 50% of payments to those models by the end of 2018. So I'm going to move into the Blue Button initiative. How many of you have heard of Blue Button? Okay, so fair number, that's good. And I think there's been a lot of confusion around Blue Button, so I just want to kind of set the record straight here that I wanted to just clarify that it's not a specific app or technology, but this is really a symbol or an indicator to consumers to get your health information here electronically. So here are some of the ways that I just wanted to illustrate how consumers are using Blue Button to get access to data, to check their electronic health record, to make corrections. We call them the second set of eyes. Sharing their health information with their care team and using apps to pull the data together and analyze the data. Some of these working better than others. So that's just a little bit about Blue Button. Blue Button started with the VA in 2010, and it was really interesting. I don't know the exact data, but Aaron might know. But Blue Button was originally started there, and they put this Blue Button on their website to see, just how many people would access, would click on it, and the actual use far exceeded their expectations. I think it was, I don't remember the exact figure, but I think it was amazing how much more people are using it, and now over 1 million vets are actually using it to access their electronic health records. So others started implementing it, and then in 2012, ONC was charged with taking it nationwide. So that it's not just available to the veteran population, but to other Americans across the nation. So this just tells you a little bit about it. In 2012 to 2015, Blue Button has been supported by the White House and their team of Presidential Innovation Fellows. We have one specifically on our team. And then today, it's a growing community, ONC, the White House, the VA, and over 500 public and private sector organizations support Blue Button through policy, standards development, thought leadership, innovation, and outreach. So this just shows you that, and this is from our 2013 consumer survey data. We have 2014 data back from the field, and it's being analyzed now, so hopefully we'll be able to present that at the end of the month at Datapalooza. But this shows that, in general, most Americans still do not have easy online access to their vital medical records. And as such, Blue Button continues this charge. This is looking at the proportion of individuals offered access to their online medical record and whether a healthcare provider or both a healthcare provider and health insurer provided that access. So as you can see here, the 28% and then breaking it down to roughly half and half there. This is a very interesting slide to me because it really shows what we hear from consumers about the patient, what they call the patient portal problem. So in And Blue Button was actually a much-needed solution to sort of help consumers better manage and coordinate their care. But this shows the average Medicare beneficiary sees 2 primary care physicians, 5 specialists, and 5 specialists working across 4 practices. So this kind of illustrates that. And there's really a need for a better solution to liquidate the data from all these disparate portals. So in a structured format, so it can be aggregated, reconciled. So that's sort of where we're going with Blue Button. This shows you how patients value their online access. 7 out of 10 individuals value online access to their health data. And then 67% in our survey showed of US adults age 65 and older say that accessing their medical information online is very important. So it really does show, break down one of the myths of health IT, that age is not a factor. This also shows the frequency of online use, and showing that 46% viewed their online record at least once, and then 54% did not access their record, so it just gives you that breakdown. And here we're getting into how the individual used online, the online record. We can see that it's for a variety of purposes, but one of the largest uses is to monitor health and checking out medications, checking test results with 73%. And then downloading the information to a computer or mobile device, 39%. And then looking at requesting, correcting errors in the online record at 10%. So you can see some of those uses for consumers. So I want to shift a little bit and talk to you about the Blue Button campaign. The objective of the campaign is twofold. And this was to create a consumer demand for access to their health information and introduce Blue Button as a brand that would signify access to health information for consumers. ONC conducted focus groups, testing and market research to inform the campaign. And what we learned is, while Blue Button is not well known, the concept is very appealing for most people, especially caregivers. And once people were exposed to this concept, many patients and caregivers were quick to embrace Blue Button and want to try it out, want to see the value, how it could be used. The campaign focused, as you can see here, on 3 population groups: adults with chronic conditions, cancer patients, and caregivers. And so all of these materials, as you see up in the upper right-hand corner, are available on our website at healthit.gov. So I encourage you to go there and look around and feel free. Some people have taken some of our PSAs that we've created and have branded them for their own use around Blue Button, have put their either their hospital or their practice information on those and have them in their waiting rooms, what have you. So definitely these are free for use for the public. These are some of our campaign supporters for the Blue Button. We announced the commitment of our Blue Button Pledge partners at the Consumer Summit last September. And this, as I said, Blue Button means to support and augment your campaign. So this is really something that we hope we can continue to partner with you all on. And again, all of the campaign resources are at our website, healthit.gov/bluebutton. So I want to talk a little bit about where we are today, and this kind of gives you a summary. I've given you a lot of background, and much of what's captured is here in this visual. So I want to pivot to our work ahead and the Consumer Action Plan, which is what my team and I have been working on for the past several months. Here it kind of shows consumer demand, compelling apps, data flowing. We need all 3 of these to happen, and increased data liquidity, innovative apps and services that bring the data to life, and consumer demand for the health information. So at this point, The first two have really begun and continue, and a lot of work supports this. And we're moving towards data flowing. In 2015, we decided to look across ONC and consolidate the work, the consumer work that was happening in all of our offices. And so my team was set with the charge of developing the consumer action plan. And this, as I'll get into more detail, is very tied to the Federal Health IT Strategic Plan and the Interoperability Roadmap. But it really does look ahead. It's a 3-year internal document that looks at where we can make significant impact to consumers towards delivery system reform and just providing more of a learning health system. And as you can see here, I'll talk a little bit more about these in more detail. We really are focused on consumer-mediated exchange. This is spurred by some of the new funding opportunities that have recently been announced, and building on ONC's existing work to advance the capture and use of patient-generated health data. So this is some of our Blue Button levers and resources. I've already mentioned our pledge community. We now boast over 650 organizations that have committed to enable Blue Button and spread the word and to give access to their data. We really also help organizations communicate Blue Button via resources such as the Blue Button PSAs, which I mentioned, and then also our Blue Button connector site. I'll talk a little bit more about that as well. Provides transparency for consumers on who and where to find health information online. And then we're going to, over the next 2 years, be moving into community-led demonstrations of Blue Button to really help advance and demonstrate the value that consumers are finding and the use of health information online. So this gets into our building blocks for the Consumer eHealth Action Plan. We, as I said, build off of of ONC's previous National Action Plan for Consumer Engagement via eHealth. This was published in Health Affairs in 2013, and it's further supported by the recently released Federal Health IT Strategic Plan and the Interoperability Roadmap, both of which are still in draft form. So specifically Goal 4, Objective A, which is empower individual, family, and caregiver health management and engagement. And Objective B, protect and promote public health and healthy, resilient communities. And the plan, as I said, coordinates our consumer-facing work, but really does show how we want to move forward with our federal partners in the private sector over the next 3 years. This is our direction and our vision. The new action plan signals this and is in alignment with these two documents, but really based on the concept of the work of the person at the center. So ONC did had several meetings and work in a white paper around putting the person at the center of care, and so this is kind of based on that, to empower each individual to actively manage their health and partner in their health care through secure access to information and interoperable technology. And this highlights our 4 pillars of the plan, which are access, contribute, use, share, and culture change. ONC will continue to work with stakeholders to ensure that all 4 of these pillars rest on a strong foundation of privacy and security that respects people's values and preferences. Patient trust in the privacy and security of their health information is very critical to the success of health IT and of interoperability. So we are working to ensure that consumers understand their rights to access their health information from a variety of sources, as I mentioned, laboratories, pharmacies, healthcare providers, hospitals. We want people to understand their personal responsibility to safeguard their health information, to understand how today providers have certain permitted uses that allow them to share information about patients and with other providers without requiring an individual's consent. So we talk a lot about consent, consolidated consent, and then to be able to assert control, for consumers to assert control over the use and disclosure of their health information when that is required by law. And this strategy, I just want to mention, is also informed by not only our consumer survey data, but our federal advisory committees, which are called the FACAs, if you have heard of those. They meet, I would say, I think it's probably every 2 months, I believe, but all of their meetings are public and they have a public comment period. So on our website, you can go and even see recorded meetings, past meetings. So a lot of those are really industry thought leaders in standards and policy. So I just wanted to encourage you to look at that resource. We also have gathered a lot of feedback from key stakeholders like yourselves. We have met with several different groups, and we continue to gather that feedback to show that the action plan is a living document that will evolve as our stakeholder needs evolve. We've had a lot of discussions with consumer advocates and patients to find out what consumers want, to find out what their expectations are. So that is also part of informing the development of this document. So I want to move into each of the pillars and tell you a little bit about what it involves. Access, the goal for access is really focused on increasing consumer electronic access to their own health information. And some of the things within this are for individuals. Health information is not always available when and where it's needed. Oftentimes it's not, as we all personally know. Patient activation relies on individuals and their family caregivers having access to electronic health information. So there's a disconnect between consumer expectation or assumptions about accessing their health information and the reality on the ground when they attempt to do this. So our action plan is really focused on increasing access through the following strategies that I'm going to tell you a little bit about. So one is consumer access to usable formats. It's not going to be very helpful or useful if we don't get access to these documents in a usable format for patients and consumers. The second one is consumer demand for their health data, reminding people that it is their legal right to access their health information electronically. And this is through our work with our Office of Civil Rights, making sure that HIPAA is actually an enabler and not blocking data. Improving consumer workflow involved in accessing information from various places. And supporting and motivating greater consumer access to all data impacting their health across different service providers, not just medical data. We know that a lot of decision-making and care happens outside of the clinical setting. So we want to make sure that patients have all data. Enabling consumers to easily find their electronic health data and navigate the digital health landscape of applications and other resources. There are over 40,000 health applications that have been created. So it's very difficult for consumers to boil that down as to the ones that are the most useful. Ensuring that policies and standards and funding mechanisms support patient access to their health data and other related information. This is about cost and treatment information. And then addressing disparities that may exist regarding consumer access to health information. We also want to focus on advancing individuals' ability to control the use and disclosure of health information, as I mentioned, within privacy and security. And last but not least, not at all least, is increasing consumers' digital health literacy. So telehealth and commercial e-visits continue to grow as a way to inject convenience across the healthcare spectrum. And a Deloitte study projected e-visit usage will likely be greatest in North America and could be up to 75 million e-visits in 2014 and 100 million globally. We, however, see this as a real opportunity to further expand the importance of giving consumers access to information post-visit to ensure continuity and coordination of care, particularly in instances where consumers have no prior relationship with online providers and may not after the visit. And this year we saw very positive support for telehealth from CMS under the criteria seen here on the screen. So in January 2015, Medicare began paying for chronic care management, and the first service to manage a patient's care that does not require a face-to-face visit. Another piece of it is that patients must have 2 or more chronic conditions, and that they will provide another opportunity for care to be improved with the assistance of telecommunication technology. So we really feel like this is very encouraging in the realm of telehealth. So our second goal is something that is in addition to what the Federal Health IT Strategic Plan covers. This is really about contribute. How do consumers collaborate with their care teams by contributing their electronic health record to their electronic health records, but really beyond that? How are we using consumers to collect information they're already tracking? How is that flowing into the EHR? But how is that actually helping them co-manage their health? One thing we know is that individuals are keepers of their health information and the historians of their medical history. So we want to build on that and leverage that. And providers base their care decisions on information they're receiving from patients, vital signs, symptoms, allergies, laboratory results, and a variety of other types of data. So I think that, patients and their caregivers shoulder the majority of responsibilities of managing their own health. A 2013 Pew report tells us 21% of patients are tracking their health on some form of technology platform. And it's important that we figure out how to capitalize on that, on the work that patients are already doing to track many of their health issues. And just this year, a new article in the Journal of American Medical Informatics Association suggested that patient-generated information could be used to fill gaps in the EHR data. So ONC is focused on enabling consumers to contribute this, as I've talked about, in the following ways: ensuring that industry standards support the capture and use of patient-generated health data in clinical and research settings; to identify and promote best practice for the incorporation of patient-generated health data in healthcare delivery; to work with providers and technology developers to provide all individuals with the ability to send and receive their health information and make decisions with their care team that are based on their preferences; and support the adoption of person-centered care, the care planning processes and tools that ensure all members of their care team have access to a consumer's health goals and preferences and information to effectively coordinate care. Our third pillar covers share and use. How are consumers sharing and using their health information? And I can tell you, not easily, not today. Increasing consumers' ability to use and share their own health information. Patients forget somewhere between 40 and 80% of medical information given immediately after the visit. And of the information remembered, half is incorrect. So that's a pretty scary statistic. 1 in 3 patients experience gaps in information exchange. And this is not surprising, since in 2013, just 39% of providers were able to exchange information electronically with other providers. Only 14% performed these exchanges with providers outside of their organizations, and only 5% exchanged information with outside hospitals. So giving consumers access to their information will help them stay organized and better facilitate exchange where it's not occurring. And I can tell you that when I speak to patients that have chronic conditions, this is one of their biggest frustrations, is that they didn't go to school for disease management. This is a burden that we have on consumers because our systems don't talk and don't exchange. We do have exchanges within hospital networks, within some states even, but it is a burden that consumers carry, and I think that that is something that really drives our work, and it helps us keep that in mind when we're sort of moving forward with this plan. So ONC will seek to support consumers being able to use and share their health information by fostering innovation to develop tools to help consumers manage information beyond EHRs, addressing technical and policy and cultural barriers to consumers being able to share their health information with trusted individuals and entities, demonstrating the high value case of consumer-mediated exchange and articulating the value proposition for all of the involved stakeholders. And then really driving at these community-led demonstrations of Blue Button. So our fourth pillar, which is probably the most challenging and where we're going to need everyone's help, is culture change. Encouraging a culture change to one that supports person-centered care and healthcare. And this is meant to inform a national conversation about how information technology can support person-centered care, really changing the social norms so it's not the exception for someone to get their health information and use it, but that is the norm. We want to do this by shining a light on bright spots, finding those successes in the field where a culture of person-centered care exists, and seeing how those can be scaled up and replicated. Engaging stakeholders in discussions like this one today about how to advance person-centered care. What does that mean? How can we get there? And advancing the understanding of consumer and provider attitudes, experiences, and the use of health IT through research and open forums. And I think we have a lot of work we're doing right now along those lines with the VA to really get at what is the experience for those on the front lines, not only for those giving access, but those asking for their health information. What are the experiences? How are providers using technology to advance patient engagement, to reach out to their patients and engage them towards better health outcomes, towards behavior change? What are the successes, but more importantly, what are the challenges and the barriers? So we really are hoping to get that from you all, and I encourage you afterwards to talk to me about this or to email my team. So there are a lot of opportunities ahead that I wanted to highlight here. We have some things that are activities that are on the horizon for us. ONC's Office of Consumer eHealth is now within the larger office of ONC, the Office of Programs and Engagement. And this is sort of manages all of our very large grants. So it allows us to work very closely with states. We've have partnerships with some of the SIM states, and we are hoping that this will also give us that way of keeping a pulse on the ground as we continue to develop and implement health IT strategies. This alignment really helps us interact with current and future ONC grantees, one in particular being our regional extension centers. And new funding opportunities, advancing interoperable health information technology services to support health information exchange, included consumer-mediated exchange as a possible focus area for grantees. And we look forward to working with those grantees in the communities. I think this will help us also with shaping the Blue Button community-led demonstrations that I mentioned. ONC is also investing in innovation, in an innovation program that launched this year. It's now closed, but we got, for the R&D challenge, but we got about 80 submissions, and we'll choose 6 of those within the next few months, and then we'll have pilots starting in 3 to 6 months around those market challenges. So the challenge really brings together providers, developers, consumers to test innovative new health products in real-time care settings. So sort of getting at, it's one way to sort of get the testing of these products in a quicker sort of time frame. And last but not least, patient-generated health data, which I mentioned a little bit about. We're sort of diving into that area over the next couple of years and looking at how we can focus that on our contribute section of the action plan. Research, updating the results of our individuals' access and use of online medical record nationwide survey with our current field data, which I mentioned. And then advancing consumer-mediated exchange and working with our Blue Button partners. How can we use this 650-plus membership to drive Blue Button and to really get it across the nation being implemented for more consumers? And this is our community interoperability and HIE funding opportunity I wanted to bring up. Because the application deadline and key dates are very important. And the reason I bring this up is because it's open eligibility. So a lot of our funding opportunities are tied to state entities, but this is really open and focused on non-eligible populations. So behavioral health, long-term care, and that type of thing. So it funds organizations for 1 year to extend an existing HIE service or use case to a non-eligible care provider population. And engaging this population to share health data across the entire spectrum of care. And the notice of intent to apply is due May 15th. So I just wanted to mention that. Applications are due June 15th, and then there's going to be an informational webinar next week on May 6th. I think lastly, we're going to do, even though it's a small amount, perhaps for some of the research or funding opportunities that you all might pursue, we're going to give up to 10 awards of $1 million each. $1 million total. So it's going to be small awards, but I think that it really will be a way to kind of get those focused funds for a population group. And this is another challenge that I really felt you all would want to know about. This is Innovating for the Underserved challenge. This kicked off on April 22nd. The challenge opened, and the deadline is July 22nd. And so the challenge seeks proposals from both nonprofit and profit teams for entities leveraging health and communication information technology and data to address one of the following key challenges for the underserved or vulnerable populations. That's access to services, childhood obesity, and connecting data between systems. So I think that this is very relevant for you all and the work that you do with the Global Science Center. The first place prize is $40,000, second place $15,000, and third place is $5,000. So again, this is really about seeking innovative approaches to increasing health equity and impacting chronic health issues in our underserved populations. So how can you get involved? I wanted to make sure you all knew the connector site. This is really important. It's our way of sort of bringing transparency to what's available on health information. We launched this last fall, and it was born out of the need to help consumers figure out how to get started. So it is still a new website. We're still populating it. So if you don't find what you're looking for there, please send us an email. It's bluebutton@hhs.gov, and let us know what you'd like to see there. But this is a great way to see what's already available, who our pledge partners are, and how consumers are using data. And I think one way is if you are a provider and you're not on this site, please let us have you listed on this site. We would really appreciate knowing about it. As I said, we're executing the Consumer Action Plan and would really need your help, your feedback as the plan is developed and implemented and rolled out. If you want to join the Blue Button Pledge Program, this is a way to do it, to work with us on becoming a pledge member and committing to liberating data. We just want to hear more stories. Tell us how you are using data. Tell us how your consumers are accessing their data, or how you're engaging your patients. What are the success stories? Because we know that they're out there, and we use these quite frequently in our work. So we really would love to hear from all of you. Be on the lookout for more of our convening sessions around Blue Button. We are really trying to distill down some of the very tough questions around consumer access, around use and exchange of health information, and we're going to be doing some Blue Button convening. So this is something that we're gearing up for our 5th annual Consumer Health IT Summit, which will happen in the fall. We hope to see you all in Washington. I believe the date that is being finalized is September 14th. So mark your calendars, and hopefully that date will stick. And then launching our community Blue Button pilots. Think of the value that librarians can play in educating consumers about online access to health information, schools wanting access to immunization data, or the nurse needing to know valuable information about allergies, and relaying EMS should an accident occur. So these are some of the use cases we're kind of developing and figuring out how to show these on a community level. And then lastly, for providers in the room, we have a really great group of health IT fellows that help inform all of the work across ONC, and we do have fellow positions opening up in May. So if you're interested in that, talk to me afterwards. I'll be able to put you in touch with Pete Carras, who handles the Health IT Fellows program. And again, I can't say this enough, please go to healthit.gov and look at the tools that we have there. We continually develop tools and resources, and I had a wonderful lunch with Dr. Bennett and several providers in the area to hear about some of the tools they're using, to hear about some of the tools they need, and so we really would like to partner with you all on this. We are updating some of our tools, so if you see something in there and say, you know, this would be great if, please share that with us, because we would like to, that's one of our roles, is really developing the resources and tools to support providers in patient engagement. This, I wanted to point out, is one way we worked with the Office of Civil Rights. This is a letter you can find on our website that really helps patients to go to their provider or their hospital, and explains that HIPAA actually protects their right to electronic health information, to accessing their records. So this is, I think, really key. And lastly, these are all the ways you can stay connected to us. We, as I said, invite you to share experiences with us. Tell us about your successes and challenges. You can follow me on Twitter, or a number of my colleagues are on Twitter. And we just really would like to hear from you of how technology is helping advance patient engagement and delivery system reform. So I will leave this up here so you all can get this information. But I really want to thank Dr. Bennett and his remarkable team for asking me to be here today, because I think it's conversations like this that really will get to the culture change that we envision. I think that I hope we can continue this collaboration in the health IT space, and I welcome you to reach out to me or my team. I'll be available at the reception afterwards, and I would love to talk to as many of you as I can. So thank you very much.
So we have a few minutes for questions, if anyone has any.
Hi, this is kind of a detailed question, but it sort of crossed my eyes as I was looking at all of, it crossed my eyes as I was looking at all my emails that I get and stuff. And that was something that happened at HIMSS that I thought was very interesting. And that was this real cry, not just for basic information in a health EHR, but for doctor's notes and for the detail. And in fact, it looked like a little bit of a revolution there. And I wondered what your take was on that.
Well, we've definitely supported open notes, and I know that we have worked with Geisinger on a study that really had remarkable results that not only showed that patients actually read the notes, used it, but even the doctor's hesitation in the beginning, really, in the end, the doctors all wanted to continue showing their notes. And so this is really about lifting the veil, and there's no, I think Open Notes is a remarkable program because oftentimes we think there's this mystery or there's this paternalistic relationship where, well, the physician can see that and share it with his colleague, but the patient can't see that. And I think this really gets at more data quality and transparency, and frankly has even shown to lead to behavior change. I mean, when somebody saw that their physician had written morbidly obese, they said, I don't want that to be said about me. I don't like that. I want to do something about that. So I think it really does help break down those barriers that sometimes exist between the provider and the patients. And Jan Walker, who heads up the Open Notes program, I'm trying to think where she's based. Do you know, Erin, where she's? Yeah. I can get you the information. Yeah, she just presented at HIMSS on it, and so I definitely could give you more information on that. But she has some remarkable statistics on how they're implementing Open Notes across the U.S. Thanks.
What's been the uptake on EHR vendors? So they are the primary ones that are basically are the key holders in terms of Blue Button APIs. Each one of the EHR vendors basically have their own portal and their own proprietary basis of exchanging information. I'm a big fan of Open Notes and the way that we have an articulation of the Geisinger, the Kaiser, the Intermountain that are really doing this in outside of a traditional framework of health information exchange. But one of the biggest obstacles is this huge conglomerate of enterprise systems that do not have a vested interest in opening it up and creating that infrastructure that the government's really pushing for.
That's a great question. Thanks. I think that, we've certainly heard that, but the market is really moving towards open APIs. And I think that it's with all the testing that's happening around it, and even within some of our own teams, it's only going to be a matter of time before I think both consumer and provider demand actually push for that. So I see that, there is hesitation, and certainly we hear that there are EHRs that are exchanging information within their systems, and there are other EHRs where they're not necessarily turning on the functionality, but I think that we're going to see that is going to be something they will have to do because the market will demand it.
Does the federal government have any policy levers to make that happen more rapidly, or is the vision that this really should be a function of consumer and provider demand? So,
in meaningful use, I can't speak too much to the proposed rule, but because we're in rulemaking right now, but this is the time for public comment. So I would encourage you to go and look at the proposed rule, because it does call for open API for that functionality to be turned on. And the public comment period ends on May 29th. There's a lot of information in it, but certainly if you would like to, if you're so inclined to comment, I think it's really important for everybody to weigh in on this.
Can you talk a little bit,
She's getting there.
about your deliberate use of the word consumer in your title and some of your words versus patient?
Sure, good question. So one thing that we struggle with too is even the use of patient. I think a lot of people, I won't say take issue with it, but I think that at the end of the day, we are people, and most of our lives are not lived out as patients, but rather people, hopefully. And I think a lot of the decisions we make regarding our care, we want to be healthy to do the things we want to do for as long as we want to do them. So I think that we use consumer and patient interchangeably. And our interoperability roadmap actually uses individuals, the word individual. So I think that that's still, a discussion we have internally. And I don't know, Erin, if you want to weigh in on that or not.
The only thing I would add to that is just that, this comes up all the time, right, the terminology, and I think, sometimes individuals, we get criticized for using that term because most people aren't acting on their own, right? Hopefully they have loved ones and other people in their lives that are looking to influence decision making, so that's why we sort of use all of the terms, patients, families, their caregivers, their loved ones, their representatives, there's hopefully we'll have sort of a support system around them.
Can I just add one comment? The federal health
Of course.
IT strategic plan
Yes.
called patient-generated health data only. There was no patient-generated health data in that. It was only self-generated health information. That's what you called it. And now you're going back to
Well, I think what it is that, it's a good point, and one thing that we did, so for the structure of the federal health IT plan, which is collect, share, use, if you all are familiar with it, we sort of did a take on that, but we really felt like contribute was missing from that, of how do, collect, share, use. One of the FACA comments that came out in the public was that this is perhaps about data and not about people, about moving data and not people. So we really wanted to think of ways that we can show how people are contributing to their care through patient-generated health data, through shared care planning processes. But I think that's a good point, because the public comment period just closed on that, and they've gotten a tremendous amount of comments around that area. So like I said, this is a draft. It's an internal document meant to help us achieve how we get to those commitments made in the Federal Health IT Plan and the Interoperability Roadmap. And because those are still evolving, our plan also will evolve. So it's good for us to hear that kind of feedback right now.
Can't see me, I'm so short. I appreciate your comment about 67% of people that are 65 and older have access, online access. And I work here in community health, and I just thought that was really interesting. It'd be interesting to see if that was stratified by income. The majority of our patients are constantly asking us, please text message me my appointment reminder. A lot of the phones, they do not have iPhones or access to that type of phone, but they have unlimited text messaging. And I was just wondering if you had any of that information that was stratified by income.
I don't know, Erin, but we can find out with our evaluation team and certainly get back to you if you'll give me your card. I do know, too, it's so interesting because I think about my grandfather when I was a Peace Corps volunteer, and We got him hooked up on AOL way back when. And he had been writing me on a typewriter a letter each week, and then he, got on AOL, and all of a sudden it was like he had all these different friends he had connected with. He was IMing everyone. He was, sending me emails to, a remote location that I barely could check, but once every month, So I think that really that is a myth that, seniors won't use it, or they don't know how to use it, or they can't. And I think with underserved populations, we've had a lot of discussion around this in DC, particularly at Unity Healthcare, and Dr. Robert Czar, who, he's done a lot of work around obesity. He's a pediatrician, so childhood obesity, and how do we figure out socially some of the social determinants of that. And he's created with the National Park Service Parks RX, which is an amazing way that he can prescribe healthy exercise at a park that's near someone's home, and also, perhaps in a safe environment, because we have crime and safety issues. But one of the points there, I think, is that he said, my clients who are low-income immigrant populations in DC, they have smartphones, and they're texting, and they want this information, and they know how to use their phone better than I do. And so it's it is a real opportunity there. So I really appreciate your comment. Thanks.
Hi, my comment was about a comment that you made earlier in your presentation around health literacy. Can you talk a little bit more about how you're tackling health literacy, both electronically and in just having access and having the literacy of reading your electronic health record and what the data says?
Well, I can tell you that we're just launching this work, so stay tuned on exactly how it will roll out. But we're partnering with the Office of Disease Prevention that's currently doing a lot of work on health literacy, and Virginia Commonwealth University Medical Center as well. There are a couple of physicians there that are doing work, testing some of the literacy messages and figuring out what really works for their patient population. One thing that's pretty clear is that in this type of environment within this industry and within health IT, we tend to use a lot of jargon. And I think even in this conversation, many of the terms that we use, you're already, eliminating people and creating disparities and, cutting people off from the communication. So I think communication is very key, and that's something we're going to be working closely with several of our federal partners. CDC has a tremendous website. I was just given a demo of it yesterday. They have health literacy courses and several levels of those, and then they link to many online resources, tools that are in several languages that have been developed. So we're going to be probably working closely with them as well to kind of take that health literacy work forward. But I think we're trying to be mindful as we move towards providing more access, that the access is not creating further disparities, especially within our marginalized and underserved populations.
So back to the text messaging thing.
Yeah.
It is a great opportunity to communicate with a lot of people of all ages and stratas, but it seems that the privacy rules keep us from using it in meaningful ways to communicate with them. Do you have a comment about that?
I don't know that I have a specific comment. I know it's been used in many different programs for, I think it's, is it Text for Babies, or what is it? Text for Babies. I know that won an HHS Innovation Award, and I know that there are lots of subpopulations that are using it. So I don't know if I can speak specifically to the privacy issues around that, but I think that one thing we're working with our privacy office on is looking at mobile technology and how we can what kind of codes of conduct or rules of the road can we create around that so that when people are using, not just texting, but when people are using applications, that the applications are actually doing what they say they're going to do. Because I think that it's sort of the wild, wild west right now, and I think that that is a concern for privacy and security. But I'm happy to look into that and give you a more informed comment.
I have a question, just to piggyback on the very first question, because I guess I'm curious if, you hear me?
I can.
Are there any EHR vendors that are supporting the Blue Button initiative or Blue Button Plus initiative as like across the board, turned on, accessible?
So when you say Blue Button Initiative, I mean, there are several people that have portals, and I think it depends on what you define as supporting the initiative. We kept it in the beginning. The bar was sort of low for what, we wanted people to do because we wanted more data to sort of get to the public. And I think the idea now is what will Blue Button 2.0 look like with APIs, with perhaps, getting more of our pledge members moved into action and using some of their commitments and leveraging those relationships. So I think that there are EHRs systems that definitely have a consumer-facing portal. They're definitely giving consumers access to their care summaries and other data, immunizations, what have you. But it really gets at functionality and the demand for it. I think that in cases where consumers and providers are asking for it and it's not being turned on, that's really a case of I think it's really a matter of time, as I was saying before. But we do have EHRs that are definitely supporting Blue Button by giving access to their data. I don't know if that really answers the question.
No, not really, but that's all right. I understand.
I mean, maybe I don't quite understand.
Well, so
what you're
here, let me
asking.
just say to what you just said about on the mobile health space, that that is wild, wild west. And the reality is that it's impossible for a technology vendor to do a whole lot of meaningful things today because the data is being locked up. And
That's
it's locked
true.
by
That's very
there's
true.
two parties. It's the HR vendors and it's also health systems. Because they have business interest into perpetuating that. And so we look at how much money we spend and taxpayers spend to promote the High Tech Act and the adoption of this technology. It's almost incomprehensible to me that during that requirements that we didn't mandate that this data, that they support this open access. And so it seems crazy to me that a lot of these words come back to be like, oh, well, hopefully consumer demand will drive this. Well, if we had that attitude, we could have just waited and not promoted the EHR, the whole move. It seems like, this seems like a really good place for the government to intervene and say, make this happen.
Like I said, I can't specifically comment on the rule because it is open for public comment right now, and it is only a proposed rule. But I think that certainly consumer demand is not going to do it, and I agree that with data not maybe only flowing to a person, it's not that the data is available for developers and innovation. So we've talked about that and how do we have some ideas about how to do that, and they're not fully developed yet, but we've talked about on a community level, how can we get more data into the hands of developers, and even maybe launching a challenge around Blue Button that would actually spur data and innovation and get it more out there. So something that would actually drive that.
That would be great.
Yes, please.
There is two, so in the 2014 certification criteria, we did require all 2014 certified electronic health record systems to have view download and transmit capabilities. So that is embedded in all those systems, and all of us have the right and the ability to get our information electronically if we want it.
It's required for the vendors to support it, but it doesn't mean they deploy it, right?
Right, so what's needed, right, in a world where direct is massively deployed, is you need trust on both sides for that action to occur, right? The data to be delivered from the system to the desired consumer endpoint. And so what an exciting development over the last couple of weeks has been the Name Trust Bundle that's come together. They have a list, but quite a number of starting to see the industry moving towards, a way to sort of, say these are trusted applications, trusted endpoints. I think we're getting there. We're certainly not there today, but it is clunky, as we made that point. You have applications like medication that are going and scraping data, so they're making it work. They're allowing people to see multiple patient portal data in one view, but it's not. It's a clunky technology. So I think we're moving towards APIs, and in the meantime, I do think some of these advancements around the trust levels are exciting to see that is happening now. Obviously, the vendors have to close those trust levels. So.
Yeah, I mean, that whole technology was a stopgap. It's inferior technology, and the fact that it's still, that's the go-to today from a technology standpoint, again, I think it's pretty abysmal, right? If that's the platform we're using, essentially secure email is our transport, So that's my opinion.
So one of the things also, just to piggyback on that, we've known that technology and engagement, SMS texting, all this are effective tools. But they've not been, the value proposition has not been. And I applaud the move from the fee-for-service to these value-based bundles. That is significantly shifting the accountability of both organizations and transition care. How those handoffs actually happen. The telehealth component, we have a CMMI grant that we're really looking at palliative care, mirroring some of the CCM as well as just end of life and the hospice carve-out and payer reform in general. The key thing with telehealth, and everyone's watching how the CCM bundle is going to work, is you're now paying for non-face-to-face services. The only way hospitals and health systems have ever been paid is someone walking through the door and something happening to them. So we talk about value-based purchasing, we talk about who benefits from keeping patients healthy. There hasn't been a value proposition of what that looks like unless you pull the bundle. In my insurance carrier employment base, that's been the key patient point. This is going to be an inflection point if you're able to now have telehealth reimbursed. Emails are not reimbursed. A physician can spend, half his day writing emails. He does not get 1 cent for that. And there's so many of these other issues that are just logistical underpinnings that has to be addressed first for the behavior modification to happen from a physician to patient relationship. So I think this is really good movement in the legislation that's moving forward. Seeing what's happened in the last just 3 years has been phenomenal. And I do think that there is this consumer demand, but also this just overall accountability that's starting to shift to put more of the regulatory kind of arm of such a huge business factor on it.
Let's be clear too, we also have a non-trivial amount of privacy issues to work out that have nothing to do with the health system.
Yeah.
If the moment that any of us picks up a consumer-based app and enters any of our data into it, we are essentially ceding control of our data forthwith. So, I think it'd be wonderful for us to build up and contribute pieces more and to give the ability of technology developers to do some more innovative things. But I think we still have quite a few issues around this idea of infrastructure and logistical underpinnings to work out before we really have a true exchange kind of a platform. There is a question in the back there.
I just wanted to also point out Erin Seminario, who's one of the key members on my team here. She's here, and she's been here interviewing a lot of providers in the area to really get at some of the research we're trying to understand. So just wanted to make sure that you all knew Erin. If you reach out to her, we're all available here too. So.
Thank you very much for your talk. I really appreciated the focus on the patient and that it was embedded in your strategy and you're trying to align it throughout the ONC and meaningful use as well. And my question right now, as we're talking about technology and everything, is can you speak to the role that your office has in governing data quality? Because we're talking about sharing a lot of data, but we're not talking about the quality of that data.
Right.
And we all know that the data is only as good as what you can use it for.
So we do work with our patient safety and data quality office in ONC. So we have a group, and this group is obviously very concerned about data quality and doing different. I can certainly share with you their work plan, but their concern is that obviously errors in the medical record have led to extremely adverse conditions for a patient and often harm. So really that is a focus area of their office, but it's embedded in this work. So other than that, we don't have, I don't have specifics right now that I could share with you, but if you want to email me, I can even put you in touch with their team as well. But I think that that is a key way we've seen. I can share with you numerous patient stories. One in particular that we shared from a caregiver in Louisiana who has a daughter who was diagnosed with allergies when she was quite young, and it turns out that 11 years later she has multiple sclerosis. But because something was copy and pasted throughout her record, it took several years for that diagnosis, that correct diagnosis, to be discovered and to actually be treated. And now she's a very thriving, teenager. But I think that there are numerous stories like this of errors in medical records, and I think that that's why I mentioned the second pair of eyes, because we have patients that can go in and say, oh, wait a minute, like that didn't, that's not me, that's not even my proper age, or those aren't my symptoms, or that's not my problem, my sort of problem issues. So I think that that's a really important area, and I'd be happy to, keep in touch with you on that.
Take one last question.
Okay.
So
Yes.
I'm curious about, this strikes me as more of a campaign rather than, Blue Button is not a place or a technology, right?
Correct.
It's an effort to really push some of those market forces that you described forward.
Correct.
And maybe we've seen some of that in the last couple of weeks when 3 of those big EHR vendors that you mentioned decided to waive their data sharing fees,
Right.
Those fees add up to tens, if not hundreds of millions of dollars in revenue from these electronic health records, right?
Yeah.
It's a big part of how they make money. So do you see this effort as continuing to pressure them to not have end dates on those fee waivers and really get them to practice the interoperability that they loathe to engage in because it's a big part of how they make money?
It looks like Dr. Bennett wants to take that question. No, I think that we hope that this will continue to put pressure not only on them but on several other sources of data. I think that, as I mentioned, we have some really big pledge members. Let's just say that we have, laboratories, we have our big, pharmacies. And one thing we're going to be looking at over the next several months is, how do we put their commitments into action, and how do we make this more meaningful? These are folks with a lot of business interests, a lot of money, and I think it's really up to us to kind of figure out, okay, now that you're a pledge member and this is great PR of Blue Button, how do we take that a step further and really turn it into an actionable commitment from our members? So I think that we're going to see more of that. I hope the pressure continues, and I think that, again, this is really moving towards that. I'm not saying Blue Button is solely responsible for that, because there's a lot of market forces, as I showed you on the slide with the perfect storm. I really feel like there's a lot of things changing in the healthcare landscape that is pushing towards this. Thank you. I'm crossing mine too.
Great. So I want to thank Lana for joining us today. Appreciate your time.
Thank you.